All right, welcome everyone. This is Yasmina Sisarak. I'm the host for this webinar. We are recording the webinar and we'll be making this recording available to you after we archive it on our YouTube channel. Email will be sent out to everyone once that is up. Usually takes about a week. So welcome to our fifth webinar in our Healthy Brain Initiative webinar series. Our webinar series are presented by the HealthMatters program, and we're located at the Department of Disability and Human Development at the University of Illinois at Chicago, and we are funded by the Centers for Disease Control and Prevention. Just as a reminder, CEUs are not offered for the webinars. Each live webinar is recorded, and like I said, we will be able to send out the archived links to you. Today's presentation is 45 minutes long. Please use chat box for comments and questions. We have a rather large crowd today. There's a 15-minute question and answer session towards the end. Today's topics is resources for older adults with intellectual and developmental disabilities, enhancement of geriatric care for all. I wanted to introduce Dr. Valerie Gress, who is a clinical associate professor at the University of Illinois at Chicago and is a geriatric researcher, clinician, and educator. She's also a director of Engage Illinois and director of interprofessional education for the College of Nursing Department of Biobehavioral Nursing Science. Dr. Gress is also one of our partners on our Healthy Brain Initiative program. Welcome, Dr. Gress, and take it away.
Thank you. Welcome, everyone. Thank you for joining us this afternoon for resources for older adults with intellectual and developmental disabilities, enhancement of geriatric care for all. This is the Healthy Brain Initiative team, and it's a pleasure for me to be working with such a collaborative team. And thank you for the invitation to present today. For today's presentation, I have no conflicts of interest and no disclosures to present. It's important. I would like to begin today by recognizing and acknowledging that the University of Illinois system carries out its missions in its namesake state, Illinois, which includes ancestral lands of Native nations. We have a responsibility to acknowledge these Native nations and to work with them as we move forward as a vibrant, inclusive institution. So these are the learning objectives for today. Upon completion of today's session, you'll be better able to define what brain health across the lifespan is, describe the role of Engage Illinois as a GWEP to increase access to care and improve health outcomes for older adults with IDD. And I'm going to be introducing you to the Engage Illinois 27 online education modules, including 2 new modules specific for people with IDD, and describe how this can benefit everyone by taking these modules. And then I'll review the strategies that can maximize engagement by people with IDD and their caregivers in healthy brain strategies. So let's go to objective number 1, defining brain health across the lifespan. As you probably know, our global population, in addition to our national population, is getting older. As you can see from the geographic map on the left, and this is the map projections for the older adult population. That's people over the age of 60. By 2030, as you can see, all of the middle blue color, those are all areas where the population of older adults is from 10 to 30% of their population. Within the next 20 years from there, the map on the right shows you a darker blue. And that darker blue area across the globe shows us areas where the older adult population will be greater than 30% of that country's population. We also know that the persons with intellectual and developmental disabilities, that population is also aging. Currently, We have 641,000 adults aged 60 and older with IDD. And by 2030, that number is projected to double to over 1.2 million. So the significance of this is that as people age, they develop more and more chronic conditions, including dementia. Currently, we have 5.3 million people in the US have a dementia, and the most common type of dementia is Alzheimer's disease, which is 60 to 80% of the cases. But by 2050, the number of older adults with Alzheimer's disease is projected to triple to 13.8 million people and could possibly be as high as 16 million people. Now, a definition of dementia. What is dementia? Dementia is the loss of memory, language, problem solving, and other thinking abilities. It's a brain disorder, and it's severe enough that it interferes with daily life. So because of that, dementia is one of the greatest healthcare burdens that contributes to dependency and disability. Unfortunately, currently, there is no cure for Alzheimer's disease and related dementias, and there are no disease-modifying treatments at this time. However, appropriate care has the potential for improving the quality of life. Typically, someone that's diagnosed with dementia can be projected to live another 6 to 8 years after their diagnosis. And some people can live up to 20 years after a diagnosis of dementia. We do know that the older the age, whether of onset, the age that they're diagnosed, then the earlier the mortality. We also know that older adults that develop a dementia or adults that develop dementias, the life expectancy goes down. Those years, the number of the years that they expect to live will go down depending on if they have comorbid or other chronic diseases. So the challenge is there's an urgent need for dementia education of clinicians, patients, and caregivers, so we can improve the ability to better understand dementia. Once we enhance the competencies to understand what dementia is and what the life experience of dementia is, we can make changes, including healthy brain lifestyle changes. Additionally, it's important for persons that develop dementia and caregivers and clinicians that we use a dementia positive approach. And what I mean by that is whether we're working with persons with dementia or we're interacting with them or with the caregivers, we need to have a positive approach because there's many things that we can do to improve the quality of life of someone who's been diagnosed with dementia. So what do we know about dementia and intellectual disability? Well, what we know is that people with intellectual disability have the same rate of dementia as the general population. However, a subgroup, a smaller group of people with intellectual disability do have some higher rates, and that includes persons with Down syndrome or traumatic brain injury or head injury. So we know that early interventions can help by adapting to changes and prolonging the lucid periods. So if we initiate programs where we promote healthy lifestyles, healthy brain initiatives, we can actually prolong the lucid periods of life. The effects of dementia can be progressive and eventually lead to death. But again, during those many years after a person is diagnosed, it's really important that we promote a better quality of life and brain healthy lifestyles. So what is not known? What we don't know about persons with dementia and intellectual disability is we really don't know which person will be affected. We also don't know how pronounced their early changes will be and what those early changes will be. As I mentioned earlier, people with dementia will experience changes and loss of memory, language, maybe their problem-solving skills, sometimes behaviors change. But again, we can't accurately predict what exact changes each person will be experiencing. And again, we can't predict how long the person will live after a diagnosis, but we do know it will be many years. So we know we have that time. It's very important to have a dementia positive approach and also to be initiating and educating people about healthy lifestyles. So let's take a look at some of the key differences in adults with intellectual disability and dementia. So we do know that the onset and duration can be different. We know, as I mentioned just a few minutes ago, persons with Down syndrome, may be more likely to develop a dementia, or persons with TBI or head injuries. The persons with Down syndrome that are diagnosed with dementia, we know their life expectancy will not be that 20 years at the longest. It usually is less than 7 years after the onset. And then some of the symptom presentation may be different. The early symptoms can be the same, except in Down syndrome where there are more notable early personality or behavioral changes. And then what else is very different about dementia and an adult with IDD is that the standard tests that we would use to assess someone and diagnose dementia are not very useful for persons with IDD. What we have to do, and what's recommended is that for persons with IDD, is that we really monitor and assess people for changes. So changes in memory or changes in behavior, because we'll notice that there's some changes with the person, and it's easy. That's the way we would diagnose them and assess them. And we'll be monitoring those changes as time goes on. So what is brain health? I've been talking to you a little bit about have a healthy lifestyle. It's important for good brain health. Well, brain health is an emerging and growing concept. It includes things like brain development, plasticity, functioning, the recovery across a life course. And good brain health is defined by the World Health Organization as a state in which every individual can realize their own abilities and optimize their cognitive, emotional, psychological, and behavioral functioning to cope with life situations. So again, it's this holistic approach that we're thinking about the emotional state, the psychological state, behavioral functioning. It's all of these things. We think of the whole person and person-centered care when addressing the person with IDD and dementia. So the Healthy Brain Initiative community of practice with the one-stop space. I'm going to be talking to you now about my program, Engage Illinois, which is a geriatric workforce enhancement federal grant. And some of the things that we've developed that are appropriate and applicable for persons with IDD. And I'm going to talk about some new education modules on brain health for persons with IDD that we're going to be developing. And I'm also going to talk about a mobile app that I developed called the Dementia Guide Expert, which is also an additional resource for people to use. So learning objective 2, I'm going to describe the role of my federal grant, Engage Illinois, to increase access to care and improve the health outcomes of older adults with IDD. So first, what is this federal grant? This was a federal grant that I was awarded through the Health Resources and Services Administration, federal government. And the grant is called a Geriatric Workforce Enhancement Program grant. And the grant is for 5 years. And this is my second award, so it's been consecutive awards. And the purpose is to enhance healthcare and caregivers and persons, older adults, help enhance their knowledge and competence, and to integrate geriatrics into primary care to improve the health outcomes of our older adult population. So what I've done is develop several different programs and strategies that actually educate clinicians, patients, caregivers, and the general public. And by educating people about healthy lifestyles as they get older, it really does change the health outcomes of older adults. So what I did was assemble an interprofessional team of healthcare experts who had a shared vision and to enhance the care provided these vulnerable populations and reduce health disparities. And I also developed strong community partnerships with government agencies, healthcare organizations, and academic medical centers to support these programs that provide best care practices. And then I created multiple innovative products and programs, several of them using technology to reach a really large audience. And those have resulted in clinical proficiency and positive practice changes and improved healthcare outcomes. And then I've also shaped the future healthcare workforce with an online education program, community healthcare programming, and health science student scholarships. So these are the 9 programs through my Geriatric Workforce Enhancement Program. My program is called Engage IL or Engage Illinois. And as you can see, there's 9 programs here, and I'm going to talk about 2 of the programs that are relevant to become resources for older persons with IDD. One of them is the Dementia Guide Expert mobile app, and the other one is an online training program that has educational modules. Some of the other programs on that figure that we just saw include senior center wellness programs. This includes health screenings that we do. We go to, prior to COVID, we were going to senior centers throughout Chicagoland and educating seniors on medications and fall risk and chronic conditions. And then we also train health professionals. So we were going to primary care clinics. In particular, we do go to FQHC clinics. So these are clinics that are in low income areas, and they actually support low income patients, minority patients, and patients with the greatest need. So we train these clinical staff at these clinics on the Medicare annual wellness visit, and we create action plans for them to actually become an age-friendly community. And then I also have a program that's assisting homebound older adults through telehealth visits. So homebound older adults are older adults residing in the home who are no longer able to leave the home. And so they are Medicare qualified as homebound, so we could bring services to them in their homes. And prior to COVID, we were doing in-person home visits. And due to COVID, we were able to create a telehealth program where they're able to have clinic visits with their providers online. In addition to that, we also put home medical devices into the home so we could be monitoring these vulnerable populations in their homes. One of my community partnership programs, I created a program called Vertical Independent Villages. This program is a collaboration with the City of Chicago Age Friendly Commission. And what we've done is we collaborated together to create a dementia education program for building management staff. As you may know, a lot of older adults in Chicago live in senior high-rise buildings. And many times they're isolated, and it's really difficult to interact with each senior. So our approach was to engage with the building management staff who are there 24/7 and who really know their residents. So we've been doing training programs with the building management staff, and we've trained over 183 building managers to date that interact with over 30,000 older adults. And when I say that we train them, we just give them general information about identifying warning signs and red flags if someone may be having some memory problems. And then once they may identify one of their residents in their building, they're able to contact the City of Chicago hotline that was established and ask that somebody come out and do an assessment. We have transitioned to virtual training. We haven't gone to the buildings because of COVID, and our webinars are going very well. Another program that we created, which is a partnership with government, is the Dementia Friendly Prison Program. And the populations in prisons in Illinois and federally also, the older inmate population has been growing quite a bit, just as our general population has been growing. And many times the older inmate that has Alzheimer's disease or dementia is misunderstood by the correction officers and the medical staff. So we have a collaborative agreement with the prison system that we've been training the medical staff and correction officers about how to identify an inmate who may be having medical problems and problems with dementia. So in the older inmate, since between 1999 and 2016, the number of people 55 or older in state and federal prisons increased by 280%. So although I gave you the numbers earlier about our national population and global population increasing, that's small in comparison to what's going on in prisons. The Bureau of Prisons has actually defined older inmates as those aged 50 and older, not 60 and older. And the reason they define them, an inmate 50 and older, as older is that they age quite a bit quicker. Through research, we have found that their chronological age is approximately 10 years, their physiological age is 10 years older. So an inmate that's 50 has the body and the physical ability of someone who's 60. So they age very quickly. So what happens is with that, we know that many of them develop chronic diseases earlier. So they're developing heart disease, they're developing dementia at a much younger age. So it's really important that we educate the prison staff, the correction officers, about what an older inmate with dementia looks like so that their behavior isn't misunderstood and that they're treated with respect and treated appropriately. Older prisoners represent 10% of the US state prison population, but in Illinois, older inmates are 18% of our prison population, which is quite a bit. And we also know older persons in prison with IDD, in the general population, persons with IDD are 2 to 3% of the population. Among the prison population, that goes up to 4 to 10% of the prison population. So it's very important that we also train the correction officers and medical staff about interacting and communicating and identifying older inmates with IDD and dementia. Oops, let me go back, hold on. So how do we improve the health outcomes of older adults with IDD? First, it begins with knowing the facts about intellectual disability that lead to projecting the needs. So we know that the average age of someone diagnosed with dementia who has IDD is 55.8 years old. So that's much younger than the general population. So we need to be aware of that. That's a fact. So we need to be aware of that so that we're screening people earlier. And we're looking for the presenting symptoms at an earlier age. We also know that the median survival time after diagnosis is much earlier, in particular because of the Down syndrome. And the median age at death with dementia would be 60 years old. So improving health comes for older adults with IDD. Again, we want to know the facts. So supporting older adults with IDD and dementia at home, it's really important that we understand, and you may know this already, that persons with IDD typically live with parents. And so they can pose new challenges for the parents who have been their primary caregivers for forever. And so many times when this change occurs, the behavior can change or deteriorate. The person may remain ambulatory for a prolonged time, but eventually they're going to become non-ambulatory, and this can be difficult for the caregiver. Their physical needs can become more prominent. So again, they're going to need more help with ADLs, activities of daily living, and things perhaps the parent and caregiver haven't been doing for a very long time. And then the caregiver themselves many times are aging parents, and they may be less capable of continuing to provide care at home. So, and this may lead to some crisis at home, so we need to be aware of that. But on the plus side, care at home enables continuity with familiar settings and people. And in the general population, when we work with persons who have been diagnosed with dementia, we really promote the idea of aging in place. It's so important for the person with dementia to remain in a familiar environment, among things that are familiar, among routines. they're able to cope, and it's just much easier for them. So with persons with IDD and dementia, many times they are living in the home and they have caregivers already in place. So that's a huge plus for them. But again, the caregiver may be an older parent who is less able to address the increasing needs of the person with IDD and dementia. The family commitment to supporting aging and problems associated with decline and value enabled if family gets support for continued home care. So again, the person will remain in the home, and it may be a caregiver who's an aging parent, but what does that tell us? That tells us that we have to increase the amount of resources that are available. Although they didn't have the need prior to the dementia diagnosis, they will have the need later. So differences in families supporting their lifelong caregivers. They have different experiences from later life caregivers related to caregiver roles and the network of support. So again, as I mentioned, their network of support may need to be increased. Their services and resources may need to be increased over time. The good thing is that the family caregivers really have extensive experience in providing support to the person with IDD and dementia. And they may be used to the personality and behaviors and even coping with those ups and downs that can happen. So they may be able to adapt to that. But again, they need the additional resources and services. So family caregivers, 75% of IDD persons reside at home, and 52% of caregivers spend at least 40 hours a week providing care, and 25% of family caregivers are over the age of 60. So learning objective 3, let's take a look at my program, Engage Illinois, 27 online education modules, and let's talk about these new modules that are going to be specific for people with IDD. So I developed a program of online learning modules related to care of the older adult. The library that we have online is 27 modules. The modules are evidence-based content. Each module, each topic was created by content experts in the field. Because they're online and it's very a flexible program, they can be accessed from anywhere because they're online. They're cost effective because they're free. And you can access one module, or you can access all 27 modules, depending on the topic that you're interested in. What was important when I designed the modules was that it really be evidence-based, because we do offer continuing education credits for healthcare professionals who are licensed and need continuing education hours. The continuing education credits are free. We offer free credits to medicine, nursing, pharmacy, social work, OT, PT, speech therapy, and public health professionals. When we first launched our program, most of our modules were taken by licensed healthcare professionals. Over the last year to 2 years, that's changed somewhat, where there's a greater interest by people who are non-licensed clinicians. So the general public, students, faculty from different universities. So it's a broader audience taking our modules. So this is a little bit tough to see. It's a little small because I wanted to fit all of the titles onto one slide, but this is a list of all the modules. So as you can see, we have topics. Each module is 30 minutes long. There are a couple modules that are 1 hour. You may start the module and come back to it at another time. Once you have set up your login information, you can go in and out of the system at your convenience, and you would just go back in wherever you finished or pause the module. Our module includes topics like caregiver burden. It includes end-of-life care, promoting geriatric health, fall risk, managing multiple conditions, nutrition in the older adult, oral health, pain management, sleep quality. So all the different things that you really would want to learn about with the older adult, and pretty much things that change as people age. one of the things about our modules was it was important to us that our modules be very engaging and very interesting. So what we designed is the modules are 30-minute videos. So I'm sure many of you go on YouTube and you watch short videos and interesting videos. And we really wanted, although they're evidence-based, we wanted it to have an engaging and entertaining type of feel to the module. So we use a documentary type of film style, with actors and as narrators. We use some animation to make it more interesting when we're trying to explain some facts and some content. And in many of our modules, I would say most of them, we have interviews. So we may have an interview with an expert in the field. Or for the dementia module, we have an interview of a caregiver who went through the journey of dementia with their loved one and talks about that experience. So again, the video interviews add to the information. And many learners relate to the videos because we're sharing these rich stories, and it just brings the facts home. Again, our film style, we use a documentary film style, and we use a lot of images, and we use a lot of infographics. And I wasn't able to show you some of the videos today, but again, a lot of the animation is moving as the narrator is talking. And so it makes it more engaging and just fun to watch, interesting. And again, all of the content was written by content experts in the field. So what is the impact of this online training library of modules? The total number of modules, these numbers are as of this summer, total number of modules completed was 28,258, and the total number of learners was over 6,000. So the reason the learners is so much smaller is that it tells you that many people take more than one module. So although we had 6,000 learners who have logged onto our system and taken a learning module, they've completed over 28,000. Over the last few months, we had an increase in use, and about 2.5, 3 weeks ago, we had 1 week where we actually had over 700 modules taken in 1 week. That was a record for us. And so I asked my tech manager to look and see what's going on. We usually have a lot, but this was exceptional. And we found out that there's a university out in California that is using our modules for one of their courses. So they're assigning our modules to their students to learn more about geriatrics. And that's fine. Our modules are free, but we're wondering about the increased usage. So it's as I mentioned earlier, these modules are made for everyone. They're made for clinicians, they're made for patients, they're made for the general public, they're made for caregivers. So they're appropriate for anyone to gain some knowledge and information. So what impact have these modules had? We have surveyed some of our program users, and we have found that they report that they've actually made changes, these are clinicians, changes in their clinical practice. And this is some of their quotes. They say that they've incorporated some of the pharmacological or medication and non-pharmacological interventions in caring for older adults. So they've adopted some of the things that we recommended. They've included some of the recommended resources to be used on instruction printouts and shared with caregivers and colleagues. So, and they've also shared it with their colleagues and other workers. Mm-hmm. So there's challenges and solutions using technology. So the challenge is we have an increasing aging population. I showed you that with this huge increase in the number of persons with dementia. So persons with dementia and their families, they need information. They need information on dementia management, treatment, resources. What is it like when I go through this journey? So one of the solutions that we came up with our Engage Illinois program was to use mobile app technology to change the way that information about dementia is given out to everyone. So why use a mobile app? There were more than, well, we probably all know this because I'm sure many of you have mobile apps on your phone. There were more than 250 million daily apps downloads between 20 and 2021 in 1 year. There will be 184 billion apps downloaded in the year 2024, which is the projection. Among all, these are all apps. Among healthcare apps that are related to healthcare, 500 million people were using healthcare mobile apps years ago, and that number has increased. And with the use of smartphones, more and more people and healthcare provider and consumers are using their phone to gain information, to access information, to put the information in their hand. So we designed a mobile app. First, we did a needs assessment, and we looked at what kind of apps are out there. You know, what isn't out there? What do people want? And what's out there? And what we found was there really wasn't an app that had been created by experts, by dementia experts, that was evidence-based. There really wasn't an app that talked about management and communication. How do you communicate with someone with dementia? What's the do's and the don'ts when they're having a behavioral disturbance? And then there weren't any apps that provided links to resources and support services that can help the person with dementia and families as they go through the journey of dementia. So we developed our concept, and our app is called Dementia Guide Expert because it guides people and was written by experts. So it's Dementia Guide Expert for persons with dementia and families and caregivers. So this is what the app looks like. The Dementia Guide Expert. You can download it for free. Our app is free. It doesn't cost anything. If you have an iOS phone, you can get it through the Apple App Store or Apple iTunes. And for an Android phone, you can get it on Google Play. Someone in Canada, actually in Montreal, created a wonderful, very short, but wonderful YouTube video. And the YouTube video talks all about the app. And it walks you through the app and tells you all the features of the app. And she did a wonderful job. So if you like to watch YouTube videos, it's very short. It's under 3 minutes. It'll just give you some more information about the app. So it was important, the benefits of a digital app, we can easily update it. So we've gone into our app multiple times to update the information so that you're getting the most recent and current evidence-based information about dementia. Again, you can download it for free. Over the last couple years, we've done something different. We were approached by a Spanish organization who had found our app and told us that there wasn't anything like this practical information available for the Spanish-speaking population. So we did convert our app into Spanish, and that's also available for free. And then we had a Korean organization that contacted us, and we also translated into Korean in 2019. So 2018 was Spanish and 2019 was Korean. Now we are working on a new version of our app. The new version, we hope to have it launched. We just finished our beta testing, and we hope to have the new version out maybe December or January. And what we've done with the new version, the English version, is we added accessibility features for persons with disabilities. So it will have multiple different types of features depending what type of disability someone has, whether they need to hear an audio for parts of it. They need to change the type. There's a feature where you can click on if you have dyslexia, and it changes the text in many different ways, so it's easier to navigate and read. So the new disability version should be coming out this month or in January. We're very excited about that. So what has been the impact of the mobile app? To date, we launched our first English version back in 2017. And as of July of this year, our app had been downloaded and viewed over 66,000 times, almost 67. By now, I'm sure it's over that times, and in 12 different countries. So people are downloading it over the globe, and that's the advantage of creating something like a mobile app, is that it's accessible to everyone everywhere. So it's been extremely, extremely popular. So learning objective 4 is maximizing engagement for people with IDD and their supports in brain health strategies. So what we're doing in our collaboration with the Healthy Brain Initiative is we're creating 2 modules. So our library of 27 modules will become a library of 29 modules. We're going to create modules that actually help healthcare providers better communicate with persons with IDD. We've decided that first we will go into the existing 27 modules, and we will create additional content that will be added to each module about managing, approaching, communicating with persons with IDD. This will be culturally relevant materials for people with IDD, and it'll go into each existing module. And also we'll have a 1-page information sheet or flyer with IDD relevant resources and links and citations. So when you go into each module on our website Engage IL is our portal to the online program. When you go to our website and you log in, you'll see that each module will have a 1-page information sheet that's relevant to persons with IDD. So one of the examples that we've actually gone through each module and talked about the upgrades that would be relevant to persons with IDD. An example was the caregiver burden module. We're going to add content on moral distress. We're going to identify risk factors associated with IDD caregiver burden, and we'll have additional resources to assist caregivers that will be available. And then we're creating 2 new modules. So our library of 27 will go to 29. So the 2 Healthy Brain Initiative modules will introduce the need to promote and disseminate evidence-based and informed home-based, community-based care interventions for people with IDD and dementia. The modules will provide an overview of brain health across the lifespan and preventing and mitigating the onset and course of dementia. So these are the 2 titles of the 2 modules that we're creating. Module 1 is called 6 Pillars for Brain Health, Promoting Equity for People with IDD. The second module is called Roadmap for Brain Health, Supporting Equitable Healthcare and Health Outcomes for People with IDD and their caregivers. This is just a brief outline of the modules because we've written the content. The first one is almost completed, and we're talking about filming already, and we're writing the script and filming. The second one is our outline. So these are the objectives for each module, and then the different sections in the module. So this is the work that we've been doing this past year. And again, the other update, again, is that new version in 2022 for our mobile app, Dementia Guide Expert. We're very excited about that. Okay, and in summary, Engage Illinois, we've created successful online geriatric training program. Our training program is engaging, accessible, free. It improves learners' proficiency and confidence and meets our goal of enhancing the care health outcomes of older adults. Our existing library of 27 geriatric modules will be enhanced to include new information in those 27 modules on culturally appropriate care for people with IDD and their care providers. And then our online program will be expanded to include 2 new learning modules that will educate health professionals to better communicate with and address the needs of people with IDD and dementia and their caregivers. And then our Dementia Guide Expert mobile app, which has been transforming dementia experience by guiding clinicians and persons with dementia and their caregivers as they navigate through the trajectory of their illness. The mobile app is being upgraded with accessibility features for persons with disabilities. Thank you very much for your attention. And I think we're going to go to our Q&A.
Thank you so much, Valerie. This is Yasmina again. Please feel free to put your questions in the chat box, and I will read them off, and Valerie can answer. But before we even get to that, since we do have sort of most of our team is here who are creating the 2 additional modules, we wanted to ask the audience, what are the types of information you would like to see that's intellectual and developmental disabilities related in these modules, and the things that you would find useful in your practice in care and support of individuals with intellectual disabilities. So that's something to just kind of comment on. We would love to hear from you about that. Valerie, what about continuing education credits for the modules? Can you clarify, do you offer those?
Yes, we do. Yes, we offer continuing education credits. If the module is 30 minutes long, obviously you get a half hour of CEUs. If it's a 1 hour module, you get 1 hour of continuing education credit for your profession. We do award that. At the end of taking the module, you can print your certificate for your CEUs, and the CEUs are free.
Thank you. All right, let me see. One of the questions is, do you see our new COVID lifestyle having an impact on the earlier onset of dementia?
Yes, we do. What we're seeing in the community is we're seeing more isolation, and social isolation has a negative impact on persons with dementia. One of the most important things for brain health is to stay active, to stay physically active, but also one of the most important things someone with dementia can do is stay socially active. And think about it, if you're engaging with people and talking with people and just having discussions and visiting, and you're stimulating your brain and you're using original thought, right? Because you're having conversations. So it's really important that you have social engagement. That's one of the most important. Music and therapy was very helpful. Physical exercise is helpful for brain health, but very important is socialization. And what we're seeing with COVID is that because of the fear of contamination and acquiring COVID, people became more socially isolated. So this has had a negative impact on persons with dementia because they're not getting stimulated. They're not engaging. And so it has had a negative impact. Yes, there are senior centers that we go to senior centers every month. Prior to COVID, every month we would go to a different senior center in Chicago, and they're very well attended. There's so many activities for the seniors. We would do educational programs and do screenings, and it was wonderful. Well, we haven't done that since COVID, and they still haven't all opened. So all of that socialization and engagement is not happening. And so, yes, it has a negative impact.
Thank you. There's one of the comments, you may want to expand on this comment. We're looking for more information on training our DSPs, direct support professionals, on how to assist our individuals with dementia. A lot of our individuals are aging, and we're seeing more with dementia. Our DSPs need to learn how to work with them and understand them and their dementia.
Right. Well, 2 of the programs that I mentioned today, the program with the building management staff in Chicago, the building managers are in their staff. It's not just the managers, it's the staff that works there at the buildings, the high-rise buildings. They are not healthcare professionals. And we created a program for them that it was easy for them to understand, what is dementia? What am I looking for? What are the warning signs? And we gave them many case scenarios of what a resident might say or do. And then we also gave them a lot of practical information in the training where we talked about do's and don'ts. If someone with dementia is behaving this way, don't do this because it may agitate them somewhat. They wouldn't understand it. When you do have a conversation, have it in a quiet place, because extra noise will distract them and they won't understand you as well. So we have all these do's and don'ts. Those do's and don'ts are also on our mobile app. So if you looked at the mobile app has 4 sections. And the first one is, what is dementia? What is it? The second section is, how do I get diagnosed? And then the third section is living with dementia, and then the future. So again, the app was designed to provide practical information. And I think that's what you're asking for the DSPs, that they need to know what is dementia, what is it going to look like, what are some of the common symptoms I'm going to see. When I communicate with someone, what are the do's and don'ts I should use? So it's that type of practical information that they need. Mm-hmm.
Thank you. Is there an assessment being developed to more quickly and accurately diagnose dementia in people with intellectual and developmental disabilities?
Yes, there are some tools that people are using. Most importantly, though, it's important that we get a baseline assessment. Since we know, when I was talking about the facts, we know that persons with IDD are going to develop dementia earlier, right? We know that. So we should start screening earlier. And when we're screening, we're really screening for cognitive, functioning, how they think. And when we do that, we need to get a good baseline reading and then continue to monitor them, I would say annually, when they have their annual physical exam. Because what we're going to see with them that's important is we're going to see a change in their level. And so we're going to see that change. So it's good to have that baseline assessment. If we don't have the baseline assessment and they come in and say they may be having problems, well, we don't know where they were before. So it's really hard to know, are they better? Are they worse? What's going on? However, a caveat to that is, as I mentioned, many persons with IDD are living with family caregivers. And many times it'll be the family caregiver that comes in and said, they're different. I see that here's some examples of how they're behaving differently. And we also see this with older adults where an adult child will bring an older adult into the clinic and report to us that I think dad is having some problems. I see that he's not, able to, drive as well anymore. He's not managing his finances. He forgets to pay his electric bill and whatever. They'll say there's changes. And so many times it's the families, the people that are close to them that'll notice that things are a little different. So we need to encourage them to comment on that and ask them, are you noticing anything different? Are there any changes? Because we really need to identify those changes and continue to monitor them. But it's important to screen, because once we start screening, then we have that baseline number. It's similar to, don't we screen people for blood pressure? And yes, we do. And we know as they get older, their blood pressure may change because we have all those readings and we know, oh my gosh, maybe now they have hypertension, we need to intervene. So we need to have those assessments done all along the way. And there are some newer tools that are developed for persons with IDD.
And Valerie, at what age would you suggest a person with Down syndrome have a baseline screening? This attendee has said, I have seen signs as young as 50 in someone.
Oh, that's pretty young. I would say if someone was that young, you could do the screening, but you may have to do a full body of neuropsych evaluation to see if there's something else going on. Here's what we do first too. When someone comes in and says there's some changes, or I think there's something going on, the first and the most important thing we do is we rule out if there's a medical issue going on. And even in my mobile app, step one is rule out medical etiology or medical cause. Because if someone has a slow thyroid, they can present with confusion and loss of memory. That's one of the symptoms. So we have to do other screening first to make sure, is there a medical issue that's going on that's causing this? Or, are they depressed? Sometimes when they're depressed, they're not initiating and they're behaving differently. Is that going on? So we really have to rule out, make sure it's not something else. And then we can go ahead and test for dementia. But as far as the age, I think 15 is pretty young. I'd have to look at the numbers to see, but that's really pretty young. I would do a full
50,
panel.
50, not
50. I'll say 50. Go 50. 5. Oh yeah, 50. I would start screening. Yes, I would start screening.
Yes, sorry.
Absolutely.
I might have been muffled.
Yeah, 50. Yes. Well, yes, of course I would. Mm-hmm.
Yeah. Another question, how long does it take to create a module and submit this for launch on the app or website?
we have a module that's coming out, gosh, that we did the script for. And that, it depends, it depends on our film editor. Sometimes, the content expert will write the content, and then we have to write the script for the actors and get the animation in and all of that. I would say 6 months. It takes at least 6 months. And that's with the filming and the film editor and all of that. And yes, at least 6 months. Yeah, it takes a while. The mobile app, we're getting much better at it now that we've done several translations. So I'm not a tech person. I'm a content person, so I will write the material. But we work with the University of Illinois team, AITS team in Urbana, and they do mobile app development, and they've been great all along. So we will just send our content to them, depending on how busy they are. The disability modifications took a long time, because we had to go back and forth to decide which features we wanted to add and how complex that is. If we have a person who's blind and needs 100% audio, is that feasible that we can do that? So that took a much longer. I would say we've been working on the disability features close to a year, and that's just modifications of the existing app. Now, we're going to be translating it next year into Arabic. I did a dementia presentation for the American University in Beirut, Lebanon, about a month ago, and they asked us to translate it into Arabic. And so I'm going to be working with their translators. That won't take as long. I would say that'll take about 8 months to do the translation.
Has there been any breakout on type of brain injury and dementia?
Any type, I say that again, Yasmina?
Any breakout on the type of brain injury and dementia?
Okay. Yes, it's different. So what we see is, because you might say, well, a lot of older adults have strokes, so that's considered a brain injury. Why don't they all develop dementia? And they don't. So it depends on the type of brain injury, and it depends how severe, like a traumatic brain injury stroke would be, for what's their incident of them developing dementia. It's not, I wish the science was more accurate. It's not. I wish there was a formula where I can say, okay, somebody with mild stroke, this is their chances. And I'm sure there's some average numbers, but it isn't an exact science, so we really can't predict it. We can predict more for Alzheimer's disease that's genetically related, because the incident of family members is higher, so that is much more likely, and it's a little more predictable. Early onset dementia from a genetic cause also progresses much faster, so that's a little bit different. But if we're talking about the garden variety Alzheimer's disease, it's not exact. But as far as the type of brain disorder, what I can tell you is what I showed you today about the Down syndrome. For Down syndrome, persons with Down syndrome, the incident goes up quite a bit of, how likely are they to get dementia? It's a little bit higher. And also the life expectancy once they're diagnosed is a little bit shorter. However, that being said, I think the most important thing we can do is to be dementia positive, and because persons that are diagnosed are going to live many years. They can have a really good quality of life. And so we just have to promote a dementia positive attitude, and also talk about things that you can do. There's no cure, but what can we do? We can promote a healthy lifestyle. We can promote brain health. We can promote activity. We can promote socialization. We can engage them in so many different programs. So there's so many positive things that we can do, that I think it's important, it's crucial that we focus on that.
Thank you. Let's see. Has the rate of dementia increased during COVID, both for people with intellectual disabilities and caregivers?
The rate? I don't think the rate has gone up itself, the rate of dementia. I think for persons with dementia, as far as their progression through and their symptoms, those have probably gotten increased. And as I mentioned earlier, related to the lack of socialization and interaction, lack of activity, people can't go out, they're less likely to walk, and I mean, they can walk, you know, in the neighborhood maybe, but they're less likely to be doing physical exercise, going to this certain center, you know, your Park District Center, whatever you were doing, you're less likely to do that because of COVID. So I think that if you had dementia, that your symptoms may be progressing a little bit more because you're not a healthy brain lifestyle, that healthy lifestyle. So I think that might impact it. As far as the incident itself, I think that it's increasing overall because people are aging, and I think that's pretty stable. But it's increasing just because of the aging population.
Thank you. We're at the hour, but there's a couple of more questions. So for those of you that have to log off, thank you so much for attending. As I said in the beginning, we have recorded the presentation and we will make it available within a week, and you will be emailed once this presentation has been archived. If some of you can stick around, I just wanted to ask a couple of more questions from the attendees, and we can be on our way. One of the questions is, I think my mom might be in early stage of dementia, but I'm not sure. I really don't know where to start. How do I get her tested? So basically the big, like, what are the first steps to kind of seek?
Right. She needs to go to her primary care provider, or if your mom is older, if she sees a geriatrician, I'm not sure, probably a primary care provider, and just she needs to report her symptoms, and they'll do a complete workup. Like, as I mentioned earlier, she needs to have a complete physical workup. So that means blood tests and there's different tests that they do now for dementia also. So they can do some biomarkers now that are available, and they are paid for by insurance. They weren't a while ago, but now they are covered by insurance. So there's screening tests they can do. What they'll first do is do like a screening test, you know, just a simple test in the office. They'll run some blood work to make sure her symptoms are not caused by something else, a medical reason. And then they can do some biomarker. And if they feel that, no, this might be an early case of dementia, they can do biomarkers. It's up to them whether they want to do any scans or not, brain scans. But I would say the biomarkers would probably be the next step for a firm diagnosis. But she needs to see her primary care provider, report the symptoms, and then ask to have a full, you know, exam and workup. And then they can rule out a medical cause, and then they can actually screen for the dementia, a possible dementia.
Thank you. And one last question. Oh, sorry. The participants with your modules and app, etc., have any of those participants asked about people with disability or information on people with disabilities while they were using your resources?
No, we haven't had anyone ask about managing and working with persons with disabilities. I think they don't know to ask. I also think, I think they don't know to ask. There's several things here, and I've talked with the team here about this before, is that, you know, ageism still exists, first of all. It's a prejudice against someone who's older, and that exists. And I think there's ageism, and then there's stigma around dementia. So you have these two factors going on. And then if you add into that someone with a disability, they just don't think of it. I think that we have to do this work. We have to increase this information and provide this information, because they don't know that they necessarily need it. They haven't thought of, well, how am I going to address someone with this disability? When I'm looking at caregiver burden, how is it different for the family caregiver of someone with IDD who's been the family caregiver for their lifetime? You know, how is that different? So we need to provide that information. So I know they haven't asked for that information. I think it's because they don't know to ask.
Thank you. I'm wondering about your high-rise project in Chicago. Have you had any people with intellectual disabilities in that project?
Yes,
or residents?
yes. There's a few. We haven't worked with anyone with group homes, but I'm sure among the populations, because it's so many people living in the high rises, and many of them are old. They're older adults, or they may be living with family caregivers too. So I'm sure, I don't know the percentage, but I'm sure that they live in the housing situations that we're dealing with. Yes, yeah. And it hasn't
Um,
been brought up, it hasn't been brought up by the building management staff yet. They haven't asked about it. Neither have the prison correction officers or medical personnel. They haven't asked about a special population, no.
Thank you, Valerie. We are 5 minutes over, so I just wanted to thank everyone for sticking around and for you presenting. We have a lot of people saying thank you. I just wanted to read one comment. This is very exciting to have such a training program for free. Your leadership is so welcome across the nation. So thank you, Valerie.
Thank you.
We will stick around to see if there are any questions, or Beth, if you had anything else to add. I will just stop recording now. Feel free to sign off. Have a great rest of the day, and we will see you in maybe a couple of months. We will be announcing additional webinars. Thank you.
Hi, this is Beth. Thank you, Valerie. This was terrific. And in regards to your high-rise and your work with the prison system, I think we talked the other day that we wonder how much training people have around intellectual disabilities, just as a baseline, let alone changes in cognition. And so I wonder if that's something, that baseline training of working with people with intellectual disabilities might be helpful as well.
Right.
Kind of like Disability 101.
Yeah, that's a great question, because I have to ask some of the building management organizations with the CEOs. I've been in contact with some of the CEOs who, like Rosen Management, some of the big management companies that manage multiple buildings, and I can ask them if that's a need among their resident populations. I would think it is, and we can also ask the building management staff when we do our trainings, and just ask them informally to give us some feedback, and ask them if that's something that they need also. It's curious that they work with seniors. They've never been trained at all about aging at all.
Right, yeah.
Yeah, they haven't. Yeah.
My guess is in both groups, people just kind of move along and do the best they can and don't think like there's help out there. They just kind of do what they have to do for their job.
Right, right. And with the prison population, the challenging issue is that when someone with dementia, an older inmate with dementia, behaves differently, they're typically punished. They receive corrective action because they're not cooperating, because they don't understand, and they're unable to. And I would assume it's the same for someone with IDD, that they don't have the capacity to understand what you're saying. So how can they comply? And then what happens is they put them in isolation. And that's the worst thing you can do for them, obviously, because then they don't get any cues. They don't understand what's going on. And usually behavior escalates also. So and we talked to the medical staff in the prisons, and we actually before we went in, we talked to all the wardens, every warden in the state, and they all acknowledged that it's a problem, that the correction officers and the medical staff somewhat really don't understand about how to handle these situations. We do appreciate that safety is the issue for them. They have to keep the inmates in line and cooperating because of safety. They have to control the environment. However, the correction officers really don't understand what's going on, and they really want to. We only did a few trainings with them, and then COVID happened, and we weren't able to go. The prisons are on lockdown. But the few that we did, and the correction officers we worked with, they had no idea. I mean, they want to improve the situation. They want to understand, but they really didn't understand what was going on. We really had explained to them, this is why they're behaving this way. This is why they respond this way. And, you know, and so it was really helpful for them. We're hoping now, once the prisons are open again, that we'll be able to go back and continue our training. And we're probably going to go to virtual training, because we won't be able to get back into the prisons as we were doing before. But they really didn't understand at all. And the poor older inmates, they just, yeah. And then when they would isolate them, it was, when I talked to the medical staff and asked them, well, when you isolate them, what happens? And they just said, oh, it's just so much worse. And I said, I would think it would be, because then they have no cueing. They don't understand what you want them to do. So yeah, it's a difficult situation.
Are you able to scale up your high-rise, Chicago high-rise project? Because I think, you know, as we've talked previously, 75% of people with intellectual disabilities live at home. And I just know in my little network of people in my community, I know quite a few people in their 40s and 50s and 60s who live on their own independently in high rises. And I think they rely on those natural supports. I wonder two things. One, about the scalability, kind of like what you're doing with the your prison project going virtual. And then two, I wonder if we've ever looked at, or if you've looked at just doing a quick survey to see how many people with IDD and with just other disabilities live there, and what their training needs might be, if that's something that we could talk about with the HBI, because I think we've always have focused on more on the community services for residential and day services, but accessing the people in the community, like you're doing with the high rise, has been a little bit more challenging.
Right. We are, for the building management staff, we are going to virtual. That's the video that's in film editing now. So it's going to come out probably in another couple months. We actually created a website just for the City of Chicago building management staff, their own website, so they don't have to go through Engage, because they don't need continuing education credits. And the city was concerned, if they went through our Engage Illinois portal, that seeing all these modules might be overwhelming, because all they need is their module related to seniors in high-rise buildings. So we accommodated them and we created their own website. So we are going to be loading that module for them on that website with additional resources and content. And they'll be able to, the advantage here, Beth, is that when it's on a website and it's virtual and they can go in and out of it at their convenience, people are much more likely to take the information, because it's convenient. You can stop, you can come back. You know, we've even had some building managers ask us for a refresher. They had our training a year and a half ago and they want a refresher. So now if we put it online, they can go back in and look again. So that's the scalability. We anticipate once we go online and they have their own website, they will just launch it across the city. And it'll be, and now we do ask people to fill out a profile so we know who's taken it and who hasn't. And so we'll know how many people are taking it. And then we'll also be able to report names to the building management company, so they get a certificate of completion and that they did the module. But I think it's going to hugely expand it and the availability of it. So scalability, yeah, going virtual online when they can access it anytime. That's a huge solution. I think it's going to be I think it's going to be really successful.
So Valerie, really quickly, we have a couple of comments from one of our attendees. Meg has said basic training on IDD and mental illness in prison population seems like it needs to be an essential training for prison staff, and would be to their benefit to know, increase their understanding and improve responses and treatment of the IDD prisoner. Mm-hmm. Since Illinois has made IDD population a huge part of their prison population, that better learn how to help the IDD prisoner, it seems like a huge disservice to the actual staff working with them to be so clueless.
I agree. I agree that they should be trained. They absolutely should be trained. It just takes someone to develop a training program. And the prison system, and the medical director that we work with, and the wardens, when we did our warden survey first, before we started, we just wanted to know, are they going to be cooperative? Do they think there's a problem? What is the need? Well, I forgot how many wardens there were, 60 something. We had 100% response from the wardens, 100%. Every warden completed the survey and said, we have a need. So they're ready. They're ready for people to come in and help them do this, help them train the correction officers, help them, improve what's going on in the prisons for the inmates. And they're very open to that. You just need someone that can develop the programs and implement the programs. But they're very receptive to it. The wardens are, the medical director, the whole prison, the administration. We presented to at their annual meeting, and overwhelmingly people came up to us. This is before we did our first training. We showed them the program, and overwhelmingly they were so grateful, thankful, couldn't wait till we came to their prison. And some of them were saying, please come to ours first. Please come to ours first. So they're open to this. If you developed a program where you could offer this kind of training and it was convenient and accessible and would benefit the correction officers, the medical staff, and the inmates, absolutely, they're very open and receptive to that. It could be done, yes.
Well, thank you again. This has been a great discussion. I am going to sign off now. We're well over time. And thank you all who stuck around with us. Have a great rest of the day. Thank you, Valerie, again.